Well, thanks, Richard, for that superb, wide-ranging overview of health, with an emphasis on England, but we will be hearing about the devolved nations after the break. Richard mentioned the impact perhaps on trainee doctors, being asked to work perhaps above their competencies. My daughter is training to be an intensive care doctor, and in the last year she's dealt with more bereavements and bereaved families than I have in 39 years as a doctor in the NHS. So I think it's a perfect segue into asking Andrew Goddard to speak next. Andrew's president of the Royal College of Physicians. I can say this as a past president of a Royal College. Royal colleges are often thought of as slightly fuddy-duddy bodies, a little bit like the House of Lords, maybe full of, been around for 500 years, lots of old people enjoying the cellars and the wine. But actually, Andrew is the youngest president for 500 years, and he brings some other things that have brought a real vibrancy and a different perspective to the Royal College of Physicians. He's a practicing clinician. He works in a large, busy frontline hospital. He's not based in London, and that's given him a perfect platform to speak next, which he's going to speak on, which is a view from the front line, which is where Andrew's certainly been during the pandemic. So, Andrew, over to you.
It's always a bit annoying when you've heard someone give your talk just before you. But what Richard has just said, I'm going to try and put in how it feels in most NHS hospitals, and hopefully a bit, although I'm not a primary care doctor, what it feels like in general practice at the moment. My wife is a GP receptionist, and I happen to believe that she has the hardest job of anybody that I've ever met, and she gets paid a remarkable £8.80 an hour. And I think that tells you a lot about our NHS. Okay. So, I was giving a similar sort of talk to some medical students the week before last, and I started with this quote, and you can see this blank look across their faces. And I had to explain all about Jaws and what it meant. And I can see that you're a similarly young audience. So I'll just remind you that what was happening was that there was a man-eating shark around the waters of what was effectively Martha's Vineyard, and a marine biologist, the local police chief, who is Roy Scheider here, and the old salty sea dog, Robert Shaw, went out to try and find this beast. And the police chief is not really enjoying this. He doesn't like being on the water, and he's chucking blood and guts into the water, and then suddenly this massive shark appears. And he steps back and he says to the old salty sea dog, "You're going to need a bigger boat." And that's what it feels like in the NHS at the moment. But of course, this is a slight misquote, and where this came from was an ad lib actually by Roy Scheider during the movie. And it's because the film crew that were filming this were in a really small boat next to this boat in the waters. And it became the standard line before they did anything any day. They said, "You're going to need a bigger boat." So I'll put up this slide because this isn't what an NHS hospital looks like, although actually it was during the pandemic, because this was a Nightingale hospital. So we invested lots of money into building these large conference centre-based hospital units, effectively, 4,000 beds, and 154 people were treated. Now, you could argue that was because we were so brilliant in the rest of the NHS that we didn't need to use them, but the bottom line was there were no staff. And this looking around for staff is probably how it feels very much. And it comes back, as Richard was talking, the workforce is how it feels. Everybody feels just need more hands and feet around. Because the urgent and emergency stuff that's queuing outside, and it's really visible, and newspapers and media love it because you can take a nice picture of a queue of ambulances, it is feeling really hard. And as Richard said, it's actually the discharge that's the problem. We've got lots of patients in hospital that we don't think need to be there, but there is nowhere to send them. And actually, the system doesn't have that much control of community care. We've spent much of the past 30 years knocking down our community hospitals and building new housing estates on them. But we need something different and somewhere to send our patients. And as Richard said, social care is in meltdown. And unless we sort social care, the NHS will follow. And you can't get away from COVID. I mean, is it really just over 2 years since we were all talking about the Wuhan wet market? And we know more about this virus now than virtually any other organism, if you can call a virus an organism, on the planet. And it's not going to go away. So this shows you the different waves that we've had over the past year and a half of different variants of SARS coronavirus 2. And I hope you can see that those waves keep coming. And they're not going to change. This is a pandemic. It's still a pandemic. It's still going to go around the world. Variants are going to crop up in other parts of the world, and they're going to come our way. So whilst politically it's very nice to think we're going back to normal, the pandemic is fizzling out. That's not true. We're going to see ongoing waves. And you can see staff in hospital just waiting. And you sort of, after a while, you just get a bit numb to it. But it's become part of normal business. And certainly for the next 2, 3, maybe hopefully not longer, we have to get used to having COVID as part of our working lives. And we can see that at the moment. So the number of hospitalisations is currently going up. And in the southwest, it's higher than it has been at any point since a year ago. Now, that's not necessarily people coming in sick because of COVID. Half or so of patients have got COVID. But that still is a problem because you can't care for a COVID-infected person in a bay with COVID uninfected patients because you'll just give it to them because it's really transmissible, which is why it's keep going around. So that restricts you in what you can do, and therefore your bed capacity is much smaller, and also that then challenges you if we want to get somebody out. So if you've got a patient that could be in a nursing care bed, but they've got COVID, that nursing home may say, well, we don't want them yet. Can you let us know when they're negative? We'll see what's going to happen over this next current wave. It feels really tight at the moment. I think the general feeling is this was to be expected when we all started roaming free again a few weeks ago, and hopefully it will settle. But it is happening a lot in Western Europe at the moment. We are seeing a rise, and other countries have followed slightly different patterns of release from lockdown. So I think we just don't know, and no one knows. However, the fact that most of those patients have come in with other conditions is good, because it means that actually we're learning to manage COVID, the disease, a bit better. Now, this is a slide of all the doctors that died in the first wave. And the big picture is one of my emergency medicine colleagues, Manjeet Riot. So the last time I saw Manjeet alive, we were in the ED together, chewing the cud, and I hadn't seen him for a couple of weeks. I gave him a big hug. You're not allowed to do that these days. But I didn't really know that the next time I would never see him again. And the next time I would hear about him, he was on ITU, and sadly he died. And I think it was the first time we started to deal with a disease that could actually get us. You sort of, as a healthcare worker, I think you either sort of adopt I don't really want to know about the dangers of this, I'll just crack on, or you almost have that invincibility about you. And COVID changed that completely. And you can see that, and particularly with long COVID, which Richard mentioned. You know, I've got a number of colleagues who got COVID in the first wave and they haven't come back to work. Or people who've got COVID and they've come back to work but they're not able to work quite as well as they were. And so it's a really, really interesting and ongoing disease for many people. But you can't look at that. I mean, that is an obvious demographic, if I can use that phrase. Where are the white doctors there? And COVID is a disease that has managed, unlike healthcare and social care, to reach the parts of our society in a way that we just wish that we could. And if you look at the ability of COVID to cause disease in people from deprived parts of our society, as you go through those deprivation cohorts upwards in deciles, you can see the mortality rate from COVID, which is the blue bars, just gets higher and higher. So it's double what it should be, over double what it should be in the most deprived people in our population compared to the least deprived people. But what you've also got on the graph is the grey side, which is other diseases. And what COVID did was it really shone the light on health inequalities. And we all knew it was there, and we've known it. There have been reports since 1980. One of my predecessors wrote the Black Report in 1980, which talked about health inequalities. And you can call it disparities, inequalities, I don't care, it's the same thing, as long as you do something about it. Politicians don't like calling it inequalities. It's not a word politicians use. But this is something we now can't ignore any longer, which is why debates about levelling up. And when it comes to trying to keep an NHS and social care profession together, health inequalities is something that we all get. The remarkable thing during COVID was we all pulled together. This was a single thing that we were all working together. We were happy to not retire, so that's why there are more people around than there were, because people haven't retired, or come back on the register. But we're all fighting, we're all in this together. Now that COVID is sort of become normal business, those uniting features are beginning to drift apart, and you can see those tensions between physicians and surgeons and anaesthetists and nurses and doctors and AHPs. And you can feel those tensions beginning to grow. But actually, if you start to talk about health inequalities and that we need to provide a health system that is fair and looks at the people who need it the most, that actually unites people again. So I think we do need to try and focus more on health inequalities. And the positive aspects, you know, we showed what we can do through data and research. If you think about all that we learned about this virus and this disease and treatments to manage it in a very, very short space of time was remarkable. The chart there shows you the death rate in hospitals, in UK hospitals, in the first wave. Okay, so this isn't, you know, with all the results that came out of recovery, which were in May. This is, as we dealt with this condition, which is a new condition for us, we talked to each other, we networked, we learnt, and we managed to get the mortality from that disease down from nearly 7% down to 1%. That was the NHS learning, sharing, and we were able to do amazing things. So we mustn't forget this, because that ability for us as a healthcare system to adapt and improve healthcare was there in spades. And the other thing, of course, is, you know, that reduction in deaths from COVID was as much because of vaccines. And I think it's reasonable for our government to take a lot of credit. You know, they took a punt, if I'm honest. It was a big punt in setting up the vaccine task force and investing in it, because no one knew. I mean, I can remember the conversations we were having in the first wave. We knew there were vaccine trials going on. We expected there was a chance that each of the vaccines that were being trialled to be about 20% effective. 20% effective. And we hoped that, therefore, if we had 4 vaccines, that would give us a reasonable shot. Now, it just happened that the first 2 vaccines were fantastic and worked in 90% of people. And we were a bit lucky there, but investing in that, a huge amount of investment, put us well ahead of the game. And I think we would be in a very different place if we hadn't done that. So you have to give credit to the government for doing that. But as I said earlier, this is a pandemic. This is a disease that affects the world. And you look at our vaccination rates, and they're very, very good. And Richard mentioned Hong Kong. But there are other countries where they are a long, long way off from vaccinating, even with 1 dose, their populations. And it's the places you'd expect. So we're going to have to pull together as a global community if we want to come up with a long-term solution for COVID. And you know, I'm a firm believer that we need to vaccinate the world. And that means that rich countries need to help poor countries. Now, there are all sorts of issues with logistics and politics and how do you keep a vaccine going in hot countries, etc. And so one model doesn't fit all, and there's no point just putting a whole bunch of vaccine on a shipping container and sending it off somewhere. It needs coordinated action, but it's something that we have to do. So the other positive was this was an era of transformation. So in 2018, I was a co-author of the document you can see there, Outpatients the Future. What we wanted to do was say, what does the future of medical outpatients look like? And how can we use that to reduce our impact on the environment and make it more sustainable in the long run. And we suggested in that document that we should make 30% of outpatient appointments virtual. I was laughed out of court by many of my colleagues, both in my own hospital, but also nationally, and by some politicians to say, don't be ridiculous, that can't happen. And then along comes COVID and bosh, 90% of consultations go virtual. And it is now beginning to balance out, and in my own practice, it's still around 40%. But it's doable. If you have the right situations and the right conditions, you can transform rapidly. And it may be the pressures that we are seeing and are going to see more and more create that crucible where we can do things differently and have to do things differently in order to survive. But that has knock-on effects, and it has perceptive effects. And Richard mentioned GPs, so I'm going to talk about GPs because they are a vital part of our healthcare system. Most patients don't end up in hospital. Most patients will deal with their GP for the majority of their conditions, or the community pharmacists. So we've really got to make sure we look after and protect our GPs. Now, sorry, Richard. I'll come back to that. No, I'll talk about that first. So there is this rhetoric in the right-wing press that primary care isn't there. And undoubtedly, getting to see your GP now is a challenge. But the Daily Mail can't make up its mind. So it wants everybody to see a GP face-to-face, but in another headline it says that it realises there aren't enough GPs, and that's why people can't get to see their GPs face-to-face. And that is the reality. We have under-resourced our healthcare system, and particularly in primary care, and we are now paying the price. So, this is from the Nuffield Trust, and as Richard will tell you, other think tanks are available. And this is the GP population using their data. As Richard said, it's mixed data, but the important line is the UK one, which is this black one, which, as Richard said, since 2009, the number of qualified GPs, whole-time equivalents, has fallen. Our population has gone up, so actually this is per population. That effect is even more magnified. So are we surprised that we're feeling the heat from that and people feel that it's less easy to see their GP? It's obviously going to be less easy to see your GP. And we've got a generally unhappy workforce, I would say. Most people are okay, they enjoy their job. If you gave them more time and more hands and feet, they would feel even better. I did a bit of work about 9 years ago on the medical registrar, who I think are the unsung heroes of most hospitals, and they are the people that generally end up looking after you when you're really sick in the middle of the night. And we went around the country doing focus groups, which were the thing at the time, to try and figure out what were the issues with being a medical registrar and how could we solve them. And after 2 of those sessions, we knew what the issues were, so we actually then started to focus on the solutions. And you can read the document, The Medical Registrar, if you want to know what the solutions are. But the problems, basically, and what made people happy were 4 things. So number 1 was workload. So that donkey represents the typical medical registrar. Could really do some powerful stuff, but unfortunately there's so many bleeps going off that disabled can't do it. The second one is teamwork. You need to feel that you're working in a team and people are supporting you. You can share the pain, bit of black humour there, but it keeps you going. You're a trainee, and actually for consultants or other doctors, that's CPD. Having ability to do that and having the time to do that is really important. That makes you feel good at work. And having flexibility that you can do the sort of job that you want to do, particularly as the demographic of the workforce changes. We need to have a more flexible workforce. Now, in the first wave of the pandemic, we stopped doing outpatient activity. We stopped doing elective activity in medicine. And all the consultants were on the wards. All the trainees were on the wards. And it was bliss from a point of view if you weren't on a COVID ward, because you actually felt like you had a team. Training was much better. The trainees felt there was somebody training them. Everybody got to know each other a bit better, and it worked really well. And there was that sort of little oasis moment where we realised if we had more workforce, this is what it would feel like. The second wave, we went back to we can carry on doing elective stuff, now carry on doing outpatients, and bosh, We went back to square one. I'm not sure that was necessarily true on my ward was a COVID ward. I'm obviously a gastroenterologist, but we became a general medicine COVID ward. And unfortunately, we were a non-escalation ward. So the decisions had already made that patients that came to us were not going to go to ITU. And in the early stages of the pandemic, we were seeing 3 patients dying per shift. It was the worst I have ever known clinical practice. And it was probably worse for the nurses, because at least as doctors, we did our ward round and then we disappeared for a bit and then came back, but the nurses were there all the time. And I've just never in my life experienced anything like that before. But there being more of us made it easier. It was hard, it was very hard, but being more of us, we shared it. And we shared that work, that really stressful work, and we supported each other. And that's why we need more people. Now, I often show this slide. I call it my graph of doom. So it's my consultant career. So I became a consultant beginning of 2002, and the blue line is emergency admissions to England. The red line is the number of beds, acute and general medical beds in England, and you can see that the two have diverged. And the only reason that the House of Cards has not collapsed so far is the green line, which is length of stay. But length of stay is now plateaued, and if anything, is going the other way, which we're seeing with infection prevention control, which is why you're now seeing ambulances queuing outside. And we're seeing that in A&E. 4-hour waiting times, going up and up and up. And that's from 10 years ago. So this isn't just a COVID phenomenon. This has been happening. The system has been slowly sludging up over a long period of time, and COVID is just giving it that little extra push. And that's cancer referrals, same shape, same length of time, things have been getting bigger and bigger. And that is the elective waiting times, which you all hear about. So, but politically, this is a huge deal, okay? And Tony Blair realised that, was why Tony Blair invested huge amounts of money at the beginning of the noughties, and why it all fell down to what was the lowest point ever, which was August 2009, and it's been going up ever since. Now, elective waiting times are something that are relatively easy to fix compared to urgent and emergency care waiting times, because you can just throw money at it and throw people at it and you can get through waiting lists. So I think we will see this fall, because if it doesn't fall and we've had a national insurance hike, then the government will not get re-elected. It becomes a major medical, and all the Ipsos Mori people will tell you this is what the public actually cares about when they forget about COVID. And the challenge from all of this is that we have an ageing population. And the older you get, the more conditions you have. And this shows you that the average age of population in hospital is around 75, and that's where that white line is. And then you can see that there aren't many people who have got no other conditions, which is the top lightest colour. And as you get darker, you see half the number of people have got 3 conditions. So we need to get better at looking after people with lots of conditions. And old people are really important in our society. Really, really important in our society. But we have to be ready for this. We have to be prepared for this increasing amount. So what this thing is, and if you haven't seen this before, this will make you stop and think. So this is data from the ONS. So we know exactly how many people we're going to have over the age of 65 over the next 20 years. And what it's doing is it's ticking through by year from 2017, the population over the age of 65. And the darkest blue is a 40% increase compared to 2017. So you can see by 2030, some parts of the country have already got a 40% increase, but by 2035, virtually everywhere has. But what you can see here is that it's happening quickly. That increase is happening really quickly. It is inevitable. Wherever you are, it's going to happen, and we know it's going to happen. So if we don't prepare our health and social care services for this ageing population, we are in deep trouble. I'll skip through that. And it comes back to the workforce. And whenever you talk to politicians, this is what Lord Kamal said in the debates about the health and social care bill. So ensuring that we have the health and care workforce that this country needs is a priority for this government. Good, well done. And the most recent figures show there are record numbers of staff working in the NHS, including record numbers of, so it's fine, we've got lots of people. So 4,000 additional doctors since 2020 in a group of probably 160,000 active doctors. We know that 30% of doctors that should have retired last year didn't, because they stayed on for COVID. And we know that the emergency register had 11,000 more people joining it because of COVID. We have not got more doctors, and we're about to see a mass exodus. We did a survey that showed that 25% of consultants, 25% of all consultants plan to retire within the next 3 years. So the only solution to that is either you try and find ways to retain staff, or you bring in staff from outside. And we're already starting to see that. There are challenges with that, but the NHS has always relied on the rest of the world. Okay, I'm running out of time, but just to say the other things that worry people, particularly our younger members of staff, are things like climate change. Climate change is real. If anybody here doesn't think it's real, I'll happily tell you why I think it's now real. And I am truly frightened by what it means. And the world that we live in at the moment is going to look very, very different in 30 years' time. The 1.5 degrees that you hear talked about, we ain't going to make. So if we're lucky and we do the right things, we will keep global warming down to 2 degrees. Even if we do that, we would expect around 2 billion of the world population to move, because they'll either be flooded or their country will be too hot to live in. So this will have a massive effect on the healthcare of the world, diseases, and healthcare and society in this country. In my qualified career, the sea has risen by 10 centimetres. It will continue to rise. 2/3 of a billion of people live below the level of the sea. Global warming is real, climate change is real, and it's going to have a significant effect. Politics is real, even if the politicians aren't always. And whilst I used to worry about Brexit, and Brexit's had a big impact, clearly there are other issues, like money. And there is no doubt that successive governments have put more and more money into health services, and we probably, you do need more money, but we are a relatively low-taxed society in the UK. And is the UK population, or is any government wanted to be re-elected in 2024, going to do anything more to taxes, particularly with the cost of living increase that we're about to see? Which brings me on to the bigger politics of Brexit. And I think that Putin's war, which I think is reasonable to call it that, will have a huge impact on the NHS and social care for the next 1-2 years. There will be a refugee impact, but the impact of the cost of living is going to widen those health inequalities. And so the sickest in our society are going to get sicker. There is going to be less money around to invest in the bits that we need to invest in. So I think the next 5 years is going to be really hard. So there are solutions. And one of the reasons we're all here is because we believe in those solutions. And tech is part of that. I would just caution, though, that trying to get IT systems that work well across the NHS is one of our big challenges. I'm not going to talk about new drugs and the challenge of having new expensive drugs versus public health. But to summarise what I've said, it's like one of those bungee cords that you use to try and keep things all together on your trailer or on top of your roof box. All these things are pulling us in different directions. Elective care versus urgent emergency care. You've got new expensive treatments versus actually we need to do more prevention. You've got primary care and traditional ways of doing things versus all the new fangled digital stuff. And politics is pulling us all ways. So it feels really, really hard in the middle. But I want to leave you with one thought. The reason that most of us in the NHS got into it in the first place is because we want to make people's lives better. And we can all continue to do that, and focusing on that is really important. So I just wanted to tell you about a little lady, not this lady, this is a random picture off the internet. I got a letter about 6 years ago from a little old lady who I'd seen in clinic 4 years before. And she said, "Dear Dr. Goddard, you won't remember me. I'm the 91 and a half, she wrote, year old you saw 4 years ago in clinic. You told me that I still had all my marbles. And I would have said that as a throwaway remark because, you know, she said, well, my doctor's worried that I might have early dementia. I said, well, you seem probably have all your marbles to me, let's carry on. And she said, I remember those words every day when I wake up. Thank you for making my life so much better. And that sort of, you suddenly realise why we do it. So if we can somehow harness that, I think we can keep the workforce going. And I think we can get through all those tensions and all those issues and everybody can pull together. So I wanted to finish with a bit of light and hope in what is a pretty dark situation. Thank you.
Well, thank you, Andrew, for that really candid and pragmatic summary of from the front line. The picture Andrew showed of ambulances reminded me, I fractured my pelvis in a cycling accident in the height of the pandemic. And when I finally got to the hospital, there were 17 ambulances queued outside. And when I finally got into the hospital, I spent 17 hours on a trolley in A&E waiting to get into a hospital bed. So that's Andrew's description is really some home truths there.